KRAS G12C mutations occur in about 3 or 4% of colorectal cancer. They act as oncogenic drivers, and they are strong negative predictors of cetuximab and panitumumab efficacy. KRAS protein cycles between GTP on and GDP off state with a protein resynthesis half-life of about 24 hours. Adagrasib is a covalent inhibitor of KRAS G12C, which irreversibly and selectively binds it in its inactive GDP-bound state. It has a long half-life, dose-dependent PK, and importantly, brain penetration. KRYSTAL-1 was a phase 1 study into phase 1b and 2. In phase 1, there was an accelerated titration design that yielded a dose of 600 milligrams BID that was subsequently studied in expansion cohorts in phase 1b and phase 2. The data presented at ESMO included adagrasib monotherapy in colorectal cancer and the combination of adagrasib and cetuximab in colorectal cancer, of course, all with KRAS G12C. The key findings. So first is safety. Both adagrasib monotherapy and combination adagrasib and cetuximab were tolerable. And second, of course, efficacy. In monotherapy, the response rate was 22%, including one unconfirmed partial response at data cutoff that remains unconfirmed to date. Median duration of response was 4.2 months. Median time to response was first assessment, 1.4 months. And at the time of analysis, 40% of patients remained on treatment. Median PFS was reached at 5.6 months. Combination therapy was even more impressive. The final confirmed response rate was 39%, and disease control rate was 100%. Median time to response was again first assessment, 1.3 months. That data remains happily immature for analysis of duration of response or progression-free survival, with 71% of patients still on treatment. In both groups, monotherapy and combination, we attempted to look for any relationship between co-mutational status and response, and none was found. The combination therapy of adagrasib and cetuximab is now being studied in phase 3 study, KRYSTAL-10, which is open in the US and soon to open elsewhere. Colorectal cancer patients with KRAS G12C have had an adverse prognosis and fewer therapeutic options than other patients. As of these results, these patients now have a promising option in the form of combined KRAS inhibition and EGFR inhibition. These results now move on to a phase 3 study, randomizing adagrasib against standard second-line cytotoxic chemotherapy, otherwise known as the fluoropyrimidine doublet the patient had not been previously exposed, so usually FOLFIRI. If that phase 3 study is successful, then colorectal cancer patients in the metastatic state with G12C KRAS may have a less toxic and more effective option moving forward. It's a very exciting time for KRAS in general in non-small cell lung cancer, colorectal cancer, and other human cancers. A variety of approaches are now being studied in combination with KRAS inhibition, and I believe that what we're seeing is only the beginning of the story.